One.
Hi everyone, welcome to researchmd.com. My name is Dr. PRAMIL. So we're going to teach you another important examination concept. It could be asked in USMLE, cardiology boards or internal medicine board, any of those kind of things. Okay, so I'm going to go through a clinical scenario and then we're going to look at what the most common wrong answer people take. So let's look at this clinical scenario the presentation is going to be. Okay. So we're going to say like an elderly patient, let's say like an 80-year-old, come with a shortness of breath, and they found this patient is in atrial fibrillation. The patient is already, so they started on metoprolol for rate control. Heart rate remains 136, and ejection fraction 30%. Okay, so this patient has CHF, and the cardioversion done. The patient on anticoagulation, still in AFib, and they're planning to do cardioversion again. Okay, so the question is, what is the long-term management? This patient will probably come back to sinus rhythm. And what is the long-term management for this patient? That's the question, okay? So what is the most common wrong answer people speak is verapamil and diltiazem. Okay, these are the most common wrong answer people usually pick. These drugs have like a negative inotropic effect, and this patient already had CHF. There's a calcium channel block, for there's no role in the long-term management. Okay, so one thing, the other points I want you to know is like it's good to know like what happens over here. Like what are the anti-arrhythmic therapy you have to pick in the management of this patient with atrial fibrillation and the long-term management. Okay, then let's look at some of the drugs we can use for long-term. Remember, the question is what is the long-term management to maintain the sinus rhythm? Okay, so what are the drugs you have? So let's the title anti-arrhythmic therapy in atrial fibrillation. Now, let's say this patient have no coronary artery disease or no structural heart disease. You can do flecainide or propofenone. They're both class 1C anti-arrhythmic drug. Okay. Now, if the patient have left ventricular hypertrophy, go with the dronedarone and or amiodarone. Okay. And then if the coronary artery disease without heart failure, you can use sotalolone or dronedarone. Okay. Now, if the patient have heart failure, most of the time you're going to see the patient with heart failure. Then go with amiodarone, or you can use dofetilide. Okay. Now, everything failed, patient remains symptomatic. Always you have to do ablation. Okay, so again, remember the atrial fibrillation management. Somebody come with atrial fibrillation, make sure always check what you do the CHACS-VAS2 score and see the patient need anticoagulation or not. Okay, that's like number one. And then initially stage you wanted to do is what rate control. You can use drugs like beta blocker. You can use amiodarone and all of those kind of things. Just when you can use calcium channel blocker, okay, rate control. You always see like when a patient in the hospital, you can put IV cardism and all that. But be careful when somebody have heart failure, don't use calcium channel blocker. Remember, they got negative inotropic effect, right? So the heart is not going to pump that much, okay? So be careful before you pick the learning point I want you to take from this case is like, be careful in which situation we can use verapamil and diltiazem, and especially the patient with heart failure, be careful. Thank you so much. God bless.